Hello, everyone, and thanks for joining us for this marketplace room on nutrition, water, sanitation, and hygiene. I'm Edwin Elizabeth Thomas, Global Planning Committee member for GHPC 2021, Project Coordinator for Center on Gender Equity and Health, UC San Diego, and your facilitator for today. As you know, this marketplace is one of the most interactive events of the conference, as well as we'll be listening to stories, ideas, and projects that organizations around the world have implemented related to child and adolescent health. We encourage you all to actively participate, ask questions, and share ideas with our presenters. Please use the chat box to type in your questions and comments during the presentations. Our speakers, Ms. Armel Sasher and Ms. Sophia San from Action Against Hunger, will kick off this room's sessions, followed by Ms. Nicole Coglianis and Professor Christine Marie George from Food for the Hungry and Johns Hopkins Bloomberg School of Public Health, respectively. I'll be sharing a bit more about our speakers before each session, so without further ado, I'll hand it over to Armel Sopiak, who will be presenting on integrating a gender transformative approach within care groups to improve nutrition outcomes and their experience around this in Cambodia. Ms. Armel Sasher is a Senior Technical Advisor on Social Behavior Change and Gender Transformation at Action Against Hunger USA, and provides technical support on behavior change in nutrition and health, water, sanitation and hygiene, and food security and livelihood. She's joined by Ms. Sopiak San, who is working with Action Against Hunger in Cambodia as the Wash and Nutrition Project Manager from 2016 to 2020. Over to you, Armel and Sopiak. Good luck.
Thank you very much. I will start to share my screen. Oh, sorry. Oh. Sorry, I got okay, small.
You're good, go ahead.
Okay, good morning or good evening, everyone, depending where you are, and thank you for attending this session. So today we will discuss about how gender dynamics may fit or not into the causal pathway of undernutrition. Although we think that it is definitely part of the equation, sometimes it's quite difficult to provide evidence about the causal role of gender inequity and undernutrition. I will let my colleague Sophia present the case study from Cambodia, and after her presentation, we'll have some time to discuss the causal pathway, and we will do a small exercise. Sophia, please, I will let you continue.
Okay. Yes. I am working in Cambodia, in Previer province. Previer province is the rural and remote province of Cambodia. And compared to the whole country, Previer had higher poverty levels, higher gender-based violence, and lower education of women, as well as higher score of the stunning and acute malnutrition. The nutrition case analysis that we can say NCA highlighted open defecation, poor hygiene, suboptimal feeding practice, lack of support from male partner, and gender inequality as some of the major factors contributing to wasting in Previer. And so, after the NCA finding, Action Against Hunger conduct a project of design co-creation with multi-stakeholder and community member, the Participatory Community Action Plan, which result in designing the community-oriented multi-sector mechanism on nutrition that we call Common Project, a 3-year project with 4 main components: was food security and livelihood, nutrition and gender. And the gender component was implemented in last 3 year project as an add-on the care group approach already in place. So the implementation, the Action Against Hunger cooperated with the local NGO that we call Beneficiary. Beneficiary is the local NGO in Cambodia. They are implementing the specialists in gender and gender-based violence. The intervention consists in selecting and training gender focal point from the community of intervention, And after the training, the focal point conduct 4 monthly group sessions with a group of women and men. Women from the care group were invited to participate in female group. Their husband or partner were invited to men groups. The participant was the voluntary. And after the finished monthly group session, the gender focal point conduct the home visit. The home visit, they work from home to home as the following follow-up activity. At the household level, they had discussion with both husband and wife. So it means that the home visit is not only work with the woman and not only work with the man. They are work with both men and women, husband and wife, and ask the question about the change in the perception and practice, and facilitate the development of the family action plan, and then visit after some time to discuss progress on the action plan. This just want to add a little bit that the action plan, the household action plan, is made by the wife and husband with facilitation from the Beneficiary organization, Beneficiary staff. So all of this is the component of the gender integrated with the nutrition, integrated in nutrition. So you can see some result from the evaluation, from the project evaluation. So Amel will be share with you some result that we finding after the intervention.
Okay, thank you very much. Please, if you have some questions for this project, and you can add your question in the chat. I forgot to mention it at the beginning. So the gender evaluation was evaluated using different methods. First, the project team conducted some different participatory learning activity with all the stakeholders involved in the intervention. And so there were male and female participants, and also people who didn't want to participate in the activity. The gender focal point, the community leader, the key actor from institution and government, and key staff from Action Against Hunger from the local partner who were involved in the implementation. So they did a number of focus group discussion, individual interview, and participatory activity during workshop to discuss the challenge, the solution, the lesson learned, the good practices of the project. In addition to this activity, we had an external evaluation made for a common project that looked at all the components of the project, including the gender one. It looked at appropriateness, relevancy, efficacy, efficiency, this kind of criteria, and with both qualitative and quantitative analysis. So the key finding from the study is that there was a general consensus on the idea that men should be involved in childcare at the end of the project, which was quite different from what we had in the baseline. Most women felt that their husband or partner was supportive in their participation in nutrition activity. So like they approved the fact that they were going to care group activity and this kind of thing. More than 70% of women felt comfortable asking support to their partner, which was something that we wanted to, where we wanted to see a change, since in the baseline this was very low. Regarding the changing practice, so it was reported that a majority of men who participated in the gender component helped bringing the child or the wife to the health center, and most of them took part in some household or childcare. Finally, in the focus group made discussion, there was some interesting reporting about a reduction in dispute and let's say violence in general at the household level. And the female gender focal point and care group leader felt higher social recognition within their community, with their husband, with the local leader. Finally, the final evaluation made a comparison of the beneficiary nutrition outcome of the package of intervention. So they were comparing what were the nutrition outcome for the beneficiaries who were participating in the gender component and the ones who didn't, because the gender component was a kind of pilot and it was not all over the project. And it was interesting to find that the participant who attended the gender intervention had a greater increase in the household diet score compared to the one who did not participate in this activity. Now, Sophia, could you tell us a bit about the lesson learned from this experience?
We have a lot of lessons learned. So, thanks, Amel. We have a lot of lessons learned, but we will present some few good practice among during the project implementation. We know that the use of the existing care group network is very effective, and it makes a platform to create the synergy between WAS, nutrition, food security, and gender component. And the second one, the constant feedback and support to gender focal points was a great motivation for them. The third one, we see that the integration of nutrition key message into the gender component have to create linkage with nutrition activity. And the next one, at the beginning, engagement men was very difficult because they are not used to participating in this type of activity. Because mostly in previous men always work in the forest and find some food from the forest to support their family. So, but with the effort to adapt group session to male old diet and lifestyle, it was possible to involve them, and most of them enjoyed the activity. The next one, the conducting home visit follow-up and facilitating the family action plan was effective to trigger reflection in a safe space. And the family plan enabled participants to set their own goal. It means the behavior that men should do were not predefined by the project. They had to discuss and come up with a goal and a plan for their family. Finally, the using participatory method thought out the project design, implementation, and evaluation is definitely a critical aspect of the project success. Here, what we can share with you, good practice during the intervention. Okay, that's all.
Okay. Okay. Thank you very much. Thank you very much. So just we had a few questions, and sorry, I wanted to answer it in the chat, but it seemed that I didn't answer to everyone. So one question was about asking if we collected during the evaluation, if we collected information from husband and wife together at home visit, and if they were comfortable with discussing GBV. So we were not, we did separated focus group discussion for men and for women. And then we also had a number of individual interviews, but we didn't discuss sensitive topic with both people together, of course, because we wouldn't create any conflict. So it was separated. And we didn't, as Sofiak explained, we didn't, so there is a question about how if we identify in the survey the type of woman that women would prefer, but no, because the idea was to facilitate a dialogue and to have the people discussing together what type of support or expectation they would have one from each other in their own household, but we would facilitate with the dialogue and action plan, but we wouldn't decide for the people what they would be expected to do. Then now we will be discussing about, so thank you, Sopiak, for presenting the case study. And now we'll discuss a bit about what are the linkage between the gender dynamics and the malnutrition pathway. So I guess most of the people who are working in nutrition sector know about the UNICEF conceptual framework for nutrition. It's the framework that many nutrition practitioners use when it comes to understanding causal pathway of undernutrition. For this discussion, we will do a small group exercise. So we'll use a whiteboard and we will use a whiteboard and we will reflect all together about some question. So I will send the link in the chat so you can access the whiteboard. On this whiteboard, you will find the UNICEF framework of malnutrition, and the idea is to think about, in this framework, we have immediate, underlying, and structural causes, and where do we think that there is a space to discuss about gender dynamics and gender norm. What are the specific aspects that are influenced by gender norm, and as practitioner, as humanitarian actor, as health actor, where do we think that these gender related aspects are actionable? So I will put the instruction here in the board. And you can share your suggestion. Okay, let me go to. I will share my screen. Okay, so if you go to this link, do you see the? Are you able to see the board?
Yes, we are.
Yeah. Okay. Sorry, it's a bit difficult to manage so many screens at a time. Okay, so if you cannot access the screen, you can still open your mic and give your idea, or you can still put your idea in the chat, and we will add it on the whiteboard. So basically, as I said, so you have different questions, and the idea is to think a bit where in the conceptual framework do we see that it is important to take in account the gender norm, because it's not specifically something that appears very strongly on the framework, although it's something that is somehow present in the causal pathway, but we don't really, it's difficult to touch upon it. So, okay. Yes, you can ask them to, so you can start by writing on the wall and add your idea. Yeah, to add your idea, you just need to add comment, and then you can ask a bit about what you think is interesting in this framework. Okay. So I will let the board open for you to think about and continue to add your idea. It's not in 1 minute that we can really discuss the matter. And so I will just come back to the presentation and we will end the session because, okay, the time is up. Okay, so thank you very much for your attention, and please let me know if you have any other question. You may take a few minutes at the end to answer it, or I can answer it in the chat. Thank you very much.
Thank you, Armel and Sophia. May I request the participants to kindly keep their board open, the whiteboard open, and fill it as we move on to the next segment of the session. So please stay with us as our next presentation is led by Ms. Nicole Coglianis and Professor Christine Marie George, who will be presenting on reducing enteropathy, diarrhea, undernutrition, and contamination in the environment, also known as the REDUCE program, and the experience around this in the Democratic Republic of Congo. Ms. Nicole Coglianis is a technical advisor with Food for the Hungry. She has over 10 years of experience in global health and clinical nutrition, primarily focusing on maternal and child health. She's joined by Professor Christine Marie George, who is an associate professor at Johns Hopkins Bloomberg School of Public Health. Her research focuses on developing and evaluating community and healthcare facility-based water, sanitation, and hygiene interventions to reduce exposures to fecal pathogens among susceptible pediatric populations and identifying environmental transmission routes for enteric infections, including cholera and shigellosis. Over to you, Nicole and Christine.
Thank you very much. My name is Nicole Coglianis, and I am with Food for the Hungry, and I'm here with my colleague, Dr. Christine Marie George, who I'll let introduce herself.
So thank you for the introduction, Edwin. And Nicole is taking the lead today on this presentation, but I'll be happy to address any questions at the end, and you can always email me. Thanks.
Thank you. All right, so I'll go ahead and share my screen here. So good morning. I'm here to present on the Reducing Enteropathy, Diarrhea, Undernutrition, and Contamination in the Environment, or the REDUCE program in DRC. Food for the Hungry is implementing the USAID BHA-funded development food security activity in South Kivu and Tanganyika provinces of DRC, with the goal of improving food and nutrition security and well-being of households. Under this DIFSA, FH is partnering with Johns Hopkins University School of Public Health and Dr. Christine Marie George for this REDUCE study. The REDUCE program focuses on identifying exposure pathways to fecal pathogens that are significant contributors to diarrheal disease and impaired growth for young children, and developing scalable interventions to reduce fecal contamination from those pathways. So the big question of why? Why did we undertake this research? Well, as we know, the first 2 years of life are when children are most susceptible to growth faltering. During this window, in many low and middle income countries, infants and young children frequently come in contact with animal and human feces and contaminated soil while crawling and playing outdoors. While exploratory play behavior is important for motor and cognitive development, in young children, this behavior also presents an exposure route to fecal pathogens for susceptible pediatric populations. Previous studies have shown an association between mouthing of soil and contaminated objects and enteric infections, environmental enteropathy, and impaired growth. Yet, there's a lack of scalable interventions to reduce exposure routes to these fecal pathogens, specifically reducing contact with domestic animals. The REDUCE intervention had 3 components: the qualitative research and the pilot study, which comprised, our formative research, and the cohort study. A prospective cohort study design was used to investigate the association between child mouthing behaviors and contact with domestic animals and diarrheal disease and impaired growth. We also investigated the association between E. coli on child and caregiver hands, in soil, food, and water, and on surfaces and objects children frequently put into their mouths, and subsequent diarrheal disease. The purpose of the qualitative research was to identify exposure pathways to fecal pathogens for young children in the DRC and identify contextual, psychosocial, and technical factors driving WASH behaviors among caregivers of young children. We then carried out a pilot for the interventions developed under the formative research. This was conducted in 2 phases, first with 30 households using 6 different technologies, and a phase 2 including 72 households and 6 care group lessons. So the cohort study included 370 children under 5, and it was conducted in the Walungu territory of South Kivu, DRC, to investigate the association between child-mouthing behaviors in contact with animals and diarrheal disease and impaired growth. Child-mouthing behaviors were assessed through caregiver reports and 5-hour structure observations. Anthropometric measurements were collected at baseline and a 6-month follow-up. During this cohort study, a risk factor analysis was conducted along with assessment of fecal exposure pathways. We also investigated the association between E. coli on child and caregiver hands in food, soil, and water, and on surfaces and objects children frequently put in their mouths and subsequent diarrheal disease. We hypothesized that environmental and hand contamination would be associated with increased diarrheal disease prevalence. We used a prospective cohort study design with 690 participants and a total of 1,923 hand rinsed soil, food, object, surface, stored water, and water source samples that were collected during unannounced spot checks after baseline enrollment and analyzed for E. coli. Caregiver reports of diarrhea were obtained for children under 5 years of age at the 6-month follow-up. For formative research, we asked, what are the existing WASH behaviors, beliefs, and preferences among households with young children? What barriers exist to improving WASH behaviors? And what opportunities exist to support and improve WASH behaviors? The qualitative research included 24 months of formative research, including 91 semi-structured interviews, 6 focus group discussions, and a pilot study of 102 households. Interviews were conducted with caregivers, community health workers, and village leaders to explore existing WASH practices and to obtain recommendations for intervention development. 60 interviews were conducted with participants in a pilot study of reduced baby WASH care group lessons to seek recommendations for intervention refinement. Intervention development focused on targeting multi-level, multi-dimensional factors driving the recommended WASH behaviors. So results, we found that child mouthing of feces and fomites, fecal contamination of the household compound, and contact with animals were associated with diarrhea and impaired growth among children in the DRC. This figure here shows that the risk factors we identified were associated with linear growth faltering or reduction of height for age Z-score. These factors included observed child mouthing of feces, feces in the child's sleeping space, and contact with animals. This work has been published in the Journal of Pediatrics, and I'd be happy to share the links after the presentation. When looking at hand contamination, we found that hand contamination is associated with subsequent pediatric diarrhea. E. coli was detected on 76% of child and caregiver hand rinse samples, 69% of soil samples from child play spaces, 54% of child food samples, and 74% of stored water samples. Children and caregivers with detectable E. coli on their hands had significantly higher odds of diarrhea at the 6-month follow-up. These findings show that child hand contamination is associated with diarrheal disease in rural DRC, and there's a high fecal contamination in child spaces and food and on food. These findings provide evidence demonstrating the urgent need to provide clean play spaces for young children and interventions targeting hand hygiene to reduce pediatric exposure to fecal pathogens. And this work was recently published in the Journal of Tropical Medicine and International Health. For our formative research, we found that parents working outside of the home, a lack of adequate child supervision, and a lack of clean child play spaces were factors driving caregivers' ability to stop children from mouthing contaminated fomites. Rice bags and plastic flooring were being used by some households as a play mat for young children, and caregivers recommended using these locally sourced materials to prevent children from touching and ingesting dirt. These findings led to the care group lesson on the use of rice bags and plastic flooring as play mats for young children. A fear of theft meant that households were keeping animals inside the home. Lack of resources to separate animals and children, and a long history of living with animals were factors driving the high contact observed between the children and small animals. To target these factors, we partnered with a local NGO that was constructing hutches for small animals with inexpensive local materials. These results were published in BMC Public Health. From these findings, the program created evidence-based interventions aimed at stopping child mouthing of feces and reducing child contact with animal feces. The program created evidence-based care group lesson plans with targeted behavior change modules and interventions that included locally sourced play mats and animal hutches for inside the home to reduce pediatric exposure to pathogens. The animal hutches inside the home came about out of concern that animals would be stolen if they were left in the yard, and using a local design and locally sourced materials, low-cost hutches for rabbits and guinea pigs were able to be built inside the home in or attached to the kitchen area. For phase 2 of the pilot of these interventions, key messages were communicated using pictorial modules for each target behavior. And for phase 2 of the project, the pilot, expanded care group lessons were developed. All care group modules were used in phase 2 included the pictorial modules from phase 1, a narrative illustration, which was a story showing what would happen if the targeted behavior was not performed, as well as an activity to be performed by the care group. Piloting these activities allowed us to obtain key stakeholder feedback, which informed modifications that needed to be made to intervention materials. Just a quick background, Food for the Hungry uses the care group model in many of our programs, including this DRC DIFSA. The care group model is a peer-to-peer education model to disseminate information in the communities, and it allows health communication programs to inexpensively go to scale. In this program, care group promoters introduce not only the care group lessons, but also the enabling technologies, the play mats and the hutches, with the accompanying behavior change pictorial module to child caregivers. The Baby Wash Care Group model that was created by Johns Hopkins University Bloomberg School of Public Health and Food for the Hungry included lessons on protecting your child from dangers in the dirt, hand washing with soap, disposal of feces, hutches for small animals, clean drinking water for families, and composting animal feces. The care group lessons and technologies were widely accepted, and the animal hutches were particularly well received by families, allowing the animals to be inside the home but contained, mainly in the kitchen, provided the security from theft while keeping the animals away from eating and sleeping in play spaces for the children. The REDUCE program is, to our knowledge, the first study to report an association between observed child mouthing of feces and linear growth faltering. The study is also unique in that the results and interventions developed by the research were immediately implemented into existing Food for the Hungry programs in DRC. Now that the research is complete, Food for the Hungry has incorporated the REDUCE findings into our existing DIFSA in the DRC, as well as other programs around the world. This module is the first baby wash care group model created, and it was created from a strong evidence base. FH has now incorporated these baby wash care group lessons into our existing modules on hygiene, as well as a new COVID-19 module. And these baby wash modules have been used in all of the health zones in the DRC DIFSA, reaching over 1 million people, including over 350,000 children under 5. Once the field testing and evaluation are complete in DRC, we will publish the finalized modules to caregroupinfo.org. So please stay tuned for that. We're excited to share those. Just want to thank our wonderful study team, including Dr. Christine Ray-George, our PI, and say that the individuals were supported by funding from USAID. This material is based in part upon work supported by USAID Bureau for Humanitarian Assistance under Development Food Security Activity, led by Food for the Hungry in South Kivu and Tanganyika provinces of DRC. Any opinion, finding, and conclusion or recommendations expressed in this material are those of the author and do not necessarily reflect the views of the partner organization or US government. Another picture of our team. Thank you. So we are now,
we are now opening up for questions.
Yes, so now we would like to have an open discussion. If anyone has any questions or would like to discuss any topics, we would love to answer and discuss with you.
And I would like to say I saw the question about the animals, and I agree that it's important to consider both the health of the animals as well as the children. And that is something that we're planning to investigate in our work. We have stool samples collected both from children as well as the animals that were in their living space. And so we'll be looking at enteric infections in the children and how those relate to enteric infections in the animals. And as I said in the chat box, if you would like our publications, please send me an email and I would be happy to send those to you. And so I see another question from Stephen about the height for age Z-scores. And so Nicole included that in our presentation. And so we did look at linear growth faltering in the children over time. And we saw that child mouthing of feces and contaminated fomites, as well as contact with animals and guinea pigs, and feces being present in the sleeping space of the child was associated with linear growth faltering.
So did the interventions and the new modules that you were implementing, do you have data that those actually then reduced those behaviors and improved any of the health metrics?
So we did it. Unfortunately, we didn't conduct an randomized control trial. However, we did conduct a pilot, and we did see improvements in environmental contamination with delivery of these interventions, and particularly less feces in the child's play spaces. Are there additional questions? So I would just like to say that we were really happy to be able to have this collaboration with Food for the Hungry, because as researchers, we tend to conduct randomized control trials kind of on our own, but not in partnership with the implementers like Food for the Hungry that are able to deliver these types of programs to millions of people. And so we really encourage all those that are part of the presentation today to try to incorporate these types of baby wash modules into the work that we're using, because we really want the work that we're doing to inform project implementation.
And I'm just putting in now the links to some of our published work so far. So if you have additional questions or want a little bit more information, I put in here. And I'd also like to echo Dr. George's. There was a wonderful collaboration between researcher and implementer, and I think that we produced some really interesting results. So very excited by the partnership as well.
And please reach out to me if you have questions about formative research that you're interested in incorporating in your own studies or potential opportunities for collaboration. I'm very interested in that.
Anything else?
All right, so thank you, everyone.
Thank you.
Thank you all. I'm just going to share on the Google chat, the Google Doc with the questions and the resources that have been put on the chat so far. I've been trying to, okay, yeah. And for those who have just sort of joined us, please leave your name on the same doc. But yeah, all those resources that has been shared so far, including the whiteboard that was shared by Armel earlier in the session, and also the resources shared by Nicole, have been compiled over here for those who are just joining us, and for easy access as well. We actually have a minute more if anybody had a question, either for this session or the previous, we could open it up. I did not expect to have more time, I will say that.
I know, surprising.
Yeah. My mentor used to say, if you open it up for questions and people don't speak in 90 seconds, that's when you start worrying. So, I think Laura sent a question and I'm going to try to find it. Yes, Laura sent a question. Did you have any differences in results by level of maternal education?
Sure. I can let Dr. George take it, or I can.
Yeah, so I can address that. So we didn't stratify our analysis by maternal education, but I agree that that's something that would be interesting to look at. And we did adjust for that in our models that we conducted to look at our associations. But I agree it would be interesting to do a stratified analysis to look at that. Excellent question. And so we did not collect information on mental health indicators, but as all of you are aware, there's a growing literature showing the importance of that. I think future studies should definitely include that.
Okay, thank you, Professor George, for taking those questions. And you're getting this session is getting a lot of compliments in the chat, and I want the speakers to observe that. So with that, I actually want to end this and thank our presenters and all of our participants for a rich and insightful discussion. As we conclude the session, I'm going to request the participants and the speakers to head back to the conference website to join other marketplace sessions, which may have one more presentation happening on the closing plenary. Thank you, everybody. I'm going to post the conference website here one more time in the chat. I hope I sent the right link, or I will be getting a very stern email from somebody.
Edwin, there are several more questions that popped up in the chat while you were talking.
Oh, okay. I may have missed it. The thing is, we have to really end the session as per the guidance I have received. But I will mine these questions and send it put it in the doc, and perhaps I have Nicole's email ID and I can send it to her.
And Dr. George put her email in there as well if you have more specific questions for her.
Yes, I can do that. All right. Thank you, everybody. And thank you to the speakers.
Right, thank you, everyone.
Thank you, Armand.
Thank you.
Thank you, Sophia. Thank you, Nicole. Thank you, Professor George. Thank you for joining us. And thank you to the folks who put in the questions. Goodbye.